I come from Sinai of Baltimore, where I serve as a vice chair, academic and fellowship director. These are my disclosures, one of which I am a physical therapist. I was a physical therapist, so I went to PT school, practiced for a year, but I was already accepted into med school, and then practiced for a couple years in med school to make some money. Here's the outline. We want to talk about how the design affects rehab. We want to talk about past, current, and future protocol for rehab. Goals of total knee, improve patient outcomes, obviously, and I think that comes in 3 buckets. My bucket today is the post-op rehab. We talked about some of the other things that are very important already. What are the goals in general? I think in life now, it's better, faster, cheaper, no matter what it applies to, whether it's your next purchase or physical therapy and your total knee. So you want to be functioning better, of course. You want to do this faster, and our insurance providers want us to do this in a cheaper way. So pretty challenging in general. So you need range of motion and flexion for certain things. So our goal is to get to about 120 degrees for normal function, minimum 105 degrees so you can descend stairs with a reciprocating gait. Traditionally, we've had some trouble. This is not a knee that's going to be easy to rehab, obviously. So instability is an issue. So if you can make your knee more stable, I think it'll allow you to rehab quicker, sooner. So I showed these slides yesterday, but a couple of people did ask me, some of the attendings, about this obviously is a press fit knee that I was kind of hesitant to start. I did a lot of press fits and training that failed miserably. As we know, the tibia has fallen to varus. Not had that same experience. I adopted this very slowly, and I've been doing press fit knees for over, 3 years now. The nice thing, you'd say, well, people have more pain. I have not seen that. Cement supposedly would give you immediate fixation and immediate ability to mobilize. I think if you make good cuts, press fit designs still are doing very well. And I've had over 2-year follow-up with my press fit knees, and they're doing well. So over 90% on press fitting. The other 10% are people on prednisone or just have really soft bone, or you all know the bone you're doing a total knee. You can almost put your thumb through the tibia. That's not one I'd even consider doing a press fit, so I'll cement those. Back to PT. So we know that after total knee arthroplasty, there is a lot of quadriceps inhibition. That's just inherent in what we do, going through the quad. So whatever quadricep strength they had before surgery, they're going to lose at least a muscle grade afterwards. So I think if we can make that quadriceps more efficient, so if you're 5 out of 5 and now are 4 out of 5 or 4- out of 5 after surgery due to quadriceps inhibition, I do think that medial design does give you some extra stability, which allows the quadriceps to work more efficiently. And this was outlined in this Nace EMG study. Again, the goal of primary knee is get back faster, and I think sagittal stability is important. So benefits of post-op rehab, if you ask me what do I do for my total hips, it doesn't matter. And of course I'm biased because I'm a PT, but hips will rehab themselves. Knees, I think you have to customize to each patient. Some patients are super motivated. They have a smartphone and they're online at home. Some of my patients, they come from a different socioeconomic standpoint. They don't have a smartphone. They can't even get online at home. So I think there's some cool stuff in the future with telemedicine and apps and all these other things, but I think post-op rehab should really be a little bit more custom, especially for our total knee patients. We know the benefits of post-op rehab, though: shorter hospital stays, less complications, and reduced utilization, which is really important in our bundled payment models that we have now. So this is kind of funny when you think about it. Just 25 years ago, these were our rehab protocols. It's pretty amazing what we used to do and what we do now. So knee immobilizer for 2 weeks. In the hospital, I remember rounding as a resident, doing dressing changes every day, seeing people for a week in the hospital. And then after that week, all right, you're going to inpatient rehab for another week. We were doing PCAs, CPMs, drains, dressing changes. Oh my gosh, I mean, just look where we came from and making it so much simpler now. I still get this question at least once a month. Some physical therapist or some nurse, usually home care, we need a CPM machine for this lady, and we know that this has not been played out as being any difference in range of motion by using a CPM machine. So if people are bugging you, I'll give you this slide so they can leave you alone. So current rehab or rapid recovery protocols, this is what it looks like for us. I think now, instead of being a week in the hospital telling people what to expect, now we spend a week before they get to the hospital telling them what to expect. So I think it's all about prehab now. So to review expectations, to go over home exercise programs, that's where it's all at. And we have a whole care coordination team. We used to have a joint class. Again, now it's online since COVID hit. So we have a clinical care coordinator that goes through all this with the patients. And I review it with them in the office too. So whenever I book patients, you know, I give my little spiel and I give them, they need to hear it a couple times, right? So I think you need to, your PA needs to, and then your nursing care or coordination team should do it. So they need to hear it multiple times. Of course, the multimodal analgesia we talked about, PT in a recovery room, and just watch when you're looking at the literature. So outpatient surgery is considered 23-hour surgery. So oftentimes when you're reading stuff, try to make it clear, because outpatient surgery from a CMS perspective is 23 hours. So they can stay overnight and still be considered outpatient, which is way different than SDS, which is same-day surgery. I tell patients there's no place like home. I agree, it is an anxiety-provoking thing for patients. When I see them in the morning, I said, if you're not nervous, you're not normal, but we got you, we're gonna support you. And there is no place like home. So encouraging people to go home. No more drains, no PCAs, no CPM, so much simpler now. Focus is not necessarily on doing your glute squeezes and your quad squeezes, but more functional activities, getting to the bathroom, getting out of bed. We don't see our patients now for about 4 or 5 weeks, so again, this prehab and pre-education stuff is very important. And then tele-rehab, we got an app for that, and we do use an app where our patients are connected early on. So 4 weeks before surgery, 2 months after surgery, we have an app which is giving them reminders. Hey, your surgery's tomorrow, don't eat after midnight. And 2 days afterwards, yes, swelling in your knees normal, warmth is normal. So they're getting these frequent reminders through their app, which is actually very, very helpful. I was kind of opposed to it initially on because I'm not a very techie kind of guy, but it has definitely helped, and patients appreciate it too. I'm just going to go through a couple phases of rehab. So obviously acute phase 1, and that's day 0 to 2. So if you're doing ambulatory surgery, it's day 0. You just want to make sure they're safe with transfers, they're walking, they're ambulating, putting weight on their knee, going over their home exercise program, giving them a couple pointers. Hey, don't put pillow under your knee, put it under your heel. So all the frequent reminders that they should have. Second phase is the 6 weeks, really just getting the scar, getting them moving, getting their quadriceps reactivated, independent ambulation. Manual therapy, so I really don't like home physical therapy. I think it's pretty worthless unless there is social problems where they can't get out. So I like people getting to outpatient therapy, having a therapist put their hands on them, doing some joint mobilizations and getting them moving. If they are having some quad inhibition or lag, we'll get some electrical stim on them. And obviously, gait training is pretty important, getting the gait, and even doing some backwards walking to facilitate that terminal extension. We talked about the different modalities we can utilize. Phase 3, this is where a lot of patients have better things to do than go to therapy. So we'll say, hey, just go once a week just to kind of have an update with your physical therapist. And now we're working on reciprocating gait and stairs and independent ambulation without assistive device. Return to sports, this is always a common question my patients have, and I still get it. Hey doc, can I go back to skiing? Or no, can I go skiing after my total knee? And I'd have a long conversation before, but now I ask one simple question: did you ski before? Well, no, I didn't ski before. Well, no, you're not going to ski after your knee replacement. So if they haven't been doing those activities like canoeing, rowing, skiing, and playing tennis, it's not something you want them to start after knee replacement. Inpatient rehab, just a couple of data sets here. It is showing that inpatient rehab doesn't make a difference. So those times where we had in a hospital stay followed by inpatient stay doesn't work from a payment bundled perspective either. We're spending the bundle all on rehab, which doesn't work in today's world. Early rehab, definitely plenty of literature to support this. The earlier you get them, the decreasing that length of stay. So early rehab and recovery protocols are important. Tele-rehab, that's defined as rehab delivered remotely using information telecommunication technologies. We do use this. We also have a knee app where we can remotely see how many steps they take, what kind of range of motion they're obtaining. One-to-one physical therapy, everyone wants individual one-on-one therapy. There's been studies that show that this doesn't make a difference either at 6 weeks. We talked briefly about our medial-pivot versus single radius gait analysis study that we did at Sinai. And we do have a lot of early data. We're still following up with data, but our 6-week data does show that timed up and go times are much better in our medial pivot. Quadricep strength is much better in our medial pivot versus the single radius cohort. Certainly this is leading to earlier mobilization and quicker rehab. So in conclusion, early mobilization is critical. Our hospital has tight margins. Our society is impatient, so getting them up right away is important. Favorable outcomes have been shown with early rapid recovery protocols, tele-rehab, and outpatient therapy. And certainly I think this is something you need to know your patients and understand which patients are motivated, which ones aren't, which ones can do it remotely, which ones can't. So thank you very much.
Thank you very much, Jim.